the Executive Director of the Michigan Health Policy Forum and the Senior Health Policy Advisor at MSU's Institute for Health Policy. I work on this project with Arnold Weinfeld and the other team member, Cindy Kyle, who's also on today, at MSU's Institute for Public Policy and Social Research, who it's that sister institute that received the Michigan Health Endowment Fund grant that supports this series of health policy issues group sessions for legislative leaders. So we thank you for joining us this morning, and thank you to the Michigan Health Endowment Fund for their generous support of this ongoing activity. This morning, we've had a little rough start, but I think we've got all our panelists now. No cause on their end, mostly on ours, and so we are going to get started. For those of you, you may be joining us for the second part of a two-part session on what we were referring to as Public Health 101. On February 7th, we held the first of the two-part series, which was on the legal aspects of the public health system in Michigan. And today's session is entitled Public Health Law in Action, Perspectives from the Field. And we are super happy to be joined with outstanding public health professionals from our local public health system in our state, who will be who are actually not going to do a presentation. It's going to be more of a discussion, and I'm really happy about trying that today versus PowerPoint presentations. So it's going to be more a dialogue that is going to include interaction between them and the executive director for the Michigan Association for Local Public Health. So as way of background, that is Arnold joining now. Arnold, I did the welcome. I was just about to kick off the topic, but perhaps you want to say, I thank the endowment fund, I welcomed people, but if you would like to say a few words, please feel free.
All I'll say is that I apologize for being late. And I too want to thank the Michigan Health Endowment Fund and Kathy and Cindy today for picking up this ball and running with it, and appreciate our collaboration with Kathy and the MSU Institute for Health Policy, and thank you to our panelists today as well.
Great, thanks, Arnold. So I think I was in the middle of saying this is the second part of this series. The first part was on the legal aspects, which is sort of foundational for this presentation, but certainly not a prerequisite for understanding the conversation today. That first session that was held on February 7th is available through recording for you to go back and view at your leisure. And this one is also being recorded, and you can view them at a later time as well. So as way of background, we believed it was important to address perhaps confusion, misinformation about Michigan's public health system through this two-part series. Historically, Michigan's public health system began in 1873 with law that was established that really created what it today is the State Health Department. Public health in Michigan has delivered under the legal authority of the Public Health Code, or PA 368 of 1978, which allows for local authority for primary responsibility of the delivery of public health prevention and control programs in our state, in collaboration, of course, and coordination with the State Health Department. In Michigan, we have one city health department, we have a number of county health departments, and then district health departments for the more rural parts of our state. It is a decentralized approach, which I think is part of what has caused confusion over time of, when it's the state health department's authority versus when it's local health department authority. But the most important point is that it's done in collaboration and coordination, not only between local and state, but local to local. And you'll hear more about that today. And prior to March of 2020, public health was rarely in the news, doing its important community health and protection work primarily behind the scenes, assuring health and safety for our communities through addressing food safety, air, water, resource, all of the things that keep our state healthy, health education and promotion. But with the pandemic of the COVID-19 pandemic, public health got thrust into the limelight, perhaps in a way, an unprecedented manner, due to the duration, scale, and severity of the pandemic's course. And during that time, local and state public health authorities and established practices, surveillance, mitigation strategies were questioned again, in an unprecedented way. And it was happening at town hall meetings and on social media and even in the news, in public record. And so, much confusion was happening, not just in Michigan, but across the country. So Michiganders and communities and policymakers were sometimes confused about the legal authority and the differences between state and local jurisdictions and the public health practices that frankly have been tried and true for decades, because of the nature and the scope and the duration of the pandemic. So we thought it would be important to kick this off with the facts. So on February 7th, we talked about the nitty-gritty legal authority and the details of the law in Michigan. And today, our session is on the practical aspects of what happens in the field, the public health professionals and the role they play, not only the COVID-19 pandemic, but all the things they do to keep our community safe. So without further ado, I'm going to introduce our speakers in alphabetical order, which means Linda Vale is always last, but only because of her name starts with V. So first I'd like to introduce Nick DeRusha. He's the health officer and the environmental health director at Luce-Mackinac Alger Schoolcraft District Health Department in Michigan's beautiful Upper Peninsula. He is currently the president of the Michigan Association for Local Public Health and treasurer of the Helen Newberry Joy Hospital Board. Nick, do you want to just give us a wave so they know that there we go? And Norm Hess, executive director of the Michigan Association for Local Public Health. Norm started his public health career over 25 years ago as a health educator and community health assessment specialist at Branch Hillsdale St. Joe District Health Department, and then spent 20 years in community health project management at the state and national levels, including the American Red Cross and the March of Dimes. Give us a wave, Norm. And Norm is also on the advisory board for the Michigan Health Policy Forum. Thank you, Norm. And Dr. Bill Nettleton, Medical Director of Kalamazoo County Health and Community Services Department and Calhoun County Public Health Department. He also serves as Associate Professor at Western's Department of Family and Community Medicine, where he sees patients and teaches resident physicians and medical students at WMed. And then again, last but not least, Linda Vale, Health Officer of Ingham County Health Department since 2014. Ingham County Health Department provides local health department services and functions, operates a network of community health centers with FQ8 with federally qualified health center status, excuse me, and provides healthcare Ingham County Jail and Youth Center. And prior to joining Ingham County Health Department, she served in Kalamazoo for 12 years, including 7 years as the health officer in Kalamazoo. So our session today is going to be different. If you've attended these in the past, you know they're usually PowerPoint presentations and then questions on, after each speaker and then again at the end. Today's session is going to be different. No PowerPoint presentations. Norm Hess is going to offer a series of discussion points that our health officers and medical director will be interacting with among each other and with Norm to help clarify our system in Michigan and some of the confusion that we've seen in the last 2 years and clarify the incredibly important role that's science-based that local public health carries out every single day. So turn it to you, Norm, to take it away.
Thank you so much, Kathy. It's really a pleasure to be here with you all. And I'm very excited about the panel that we have put together for you. We have 2 health officers and 1 medical director. And we're going to talk a little bit about those 2 roles and what they mean and how they interact. If you're not familiar with the Michigan Association for Local Public Health, we are the professional association for all 45 of the health departments in Michigan. As Kathy said, there's 1 city health department in Detroit. We have 30 single county health departments, and we have 14 that cover more than 1 county, sometimes up to 10. So with that, I'm going to, pardon me, I'm going to ask Nick to kind of start us off. Nick, a lot of people are not really all that familiar with the role of the health officer in local public health. I'm wondering if you could give us a little bit of a background on that position and kind of what are the primary responsibilities you see in your role as a health officer?
Sure, thank you, Norm. Yeah, the local health officer serves as the chief administrative officer of a local health department. So we are responsible on a daily basis to ensure that our local health department is doing everything we can do with the services that we provide to help keep our community safe. Local health departments have both environmental programs and we have personal health programs. We have programs for maternal child health and a wide array of offerings across the state based on local needs. The health officer works close with our local governing entity with a single county health department. That's often the county commission. Sometimes they appoint a board of health. For a district health department, it is a board of health and it's made up from 2 commissioners of each of the counties that the department serves. In addition to that, a local health officer serves as the chief local strategist. So we'll work with the local governing entity. We will work with other agencies within our communities. We'll work with the state health department, tribes, other partners, business community, and do what we can to plan and implement programs within our communities to provide services that help keep our residents safe and healthy. Most times that work goes on quietly behind the scenes and it's not super public. In COVID times, we had a bright light shined on the work that we do that really, as Kathy had mentioned, was unprecedented. So a lot of our work was in the spotlight, which was really unusual for us, but nonetheless, we kept doing the things that we needed to do to utilize our departments to help keep our community safe and prevent disease within our communities. So that really is the role of a local public health officer. Usually it's quiet work, doing things to help keep our community safe and our departments running efficiently. In COVID times, it was very, very public, but that is rare, very rare, some of the things that were necessary in COVID times.
Thanks, Nick. And how long have you served as the health officer at Luce, Mackinac, Alger, and Schoolcraft District Health Department?
I've been the health officer here at the department since 2009.
Okay, so a few years. Linda, I have a question for you to follow up, but before I ask it, I wondered if you had anything to add to what Nick has said about the responsibilities of the health officer.
No, not really. I mean, it will vary some, like, in our department, as you've explained in my bio, we have a few things that the health department is responsible for, and you'll see it in some health departments. Animal control, part of a health department. In our department, medical services for both the jail and the youth center. So you'll see some variation with some kind of additional things beyond kind of that core role. And disease control, of course, is what we've seen most during COVID response.
Right. And you have also been a health officer for a few years in a couple of different health departments, isn't that right?
I have been a health officer for 15 years, 2007.
Okay. So if you can take your mind back to before COVID started, which was 2 years ago, but seems like 20. Can you give us a few examples of some of the public health emergencies before COVID that you had to lead your community through, and how you provided leadership to kind of mitigate those situations?
Well, I guess I'll go back to Kalamazoo. Of course, we had 1 million gallons of oil that spilled into the Kalamazoo River, which impacted both Calhoun and Kalamazoo County, which required basically a no contact order for the river, and really large incident command interactions with the EPA, the U.S. Department of Agriculture and Natural Resources, locally at the state level, Department of Environmental Quality, Department of Health and Human Services, as well as, of course, at the local level with our emergency management folks, as well as, again, public health from both Calhoun County and Kalamazoo County, as the oil flowed down really to a dam at Morrow Lake, which is in Kalamazoo. In addition to that, some smaller things like, orders to, I had a gentleman who left a hospital, actively tuberculosis and HIV, and was on his way back to a homeless shelter with active tuberculosis. And we had to deal with that issue with what we call a warning notice, which, similar to an epidemic order, is for an individual rather than a group. We, of course, dealt with Ebola, as much as it was not really an emergency that we saw emerge here. It did cause quite a lot of community unrest. We had a local fire department respond to a individual who was sick in a mall here, and go in with bio protection gear and things like that. So we really had to do a press conference for our community and really explain where we were with Ebola and what the likelihood of Ebola was here. We've all dealt with even Zika virus, which was another thing that didn't happen here, but was something that was of concern. We also, I'm sorry about that. We also dealt with the EEE threat and things like that. I will apologize. I am wearing unprofessional gear because I went up north to go skiing and I forgot that I was supposed to, in addition to bring my computer, bring something that looked decent to wear for a webinar. And for some reason, only my rear facing camera is working on my computer, so I cannot mute myself because it's over there. Anyway, so really it is just, all of those things that you hear in the news about, mosquito-borne illnesses like, Eastern equine encephalitis, Western equine encephalitis, West Nile virus, and many others that we have responded to over the years.
Thank you. So it sounds like you deal with situations that may affect only an individual, but also a more widespread impact across your county. And then I think it's interesting that you brought up that sometimes there are public health threats in other areas of the state, the country, or the world, but people hear about them. And so it sounds like a good deal of your work has to do with communicating what the threat is, what steps people need to take, if any, and sometimes to sort of reassure the public that what you're hearing on the news is not a direct threat at this time. So that sounds complicated.
Yeah, basically a lot of information and education. I mean, public health really is quite a bit of health education around, anything that is perceived as a threat or is a threat in the community, as well as just general public health education about how we go about life in ways that keep us safe and healthy.
Right. Okay, thanks. Thanks, Linda.
So Norm, maybe I can provide some additional tangible examples as well as response to public health emergencies. So I remember, for example, standing with community leaders in Kalamazoo County at 10 p.m. at night, advising the citizens of Parchment not to drink the water, given the concern for municipal water well contamination with an emerging chemical called PFAS. And that's a big deal, to tell more than 3,000 people not to drink the water. And what does that mean for an individual self, for a community self? And then to take action and provide, drinking water for that community. That meant coordinating a multi-layered response with the federal, state, local government, working with local high school. We had local high schooler football players passing out water the next day at the high school parking lot. We were communicating to the public at a time when the knowledge around PFAS was still emerging. I remember that a few nights later, standing in front of 800 people at a local church, bringing folks along about what this means for their community and was their health already affected and would it be affected in the future, addressing that risk communication. That also, I also experienced that in smaller towns as well with the PFAS exposure response. In Battle Creek, in Richland, all had different types of exposures that required different types of assessment and risk communication. I also recall advising in Battle Creek for infants not to drink water when there was a concern for a chemical or an element called manganese. So imagine that if you were a mom who you hear on the news, you shouldn't give water to mix with your formula for your baby. That was public health response and public health risk communication. It was brought up about the Eastern equine encephalitis outbreak, a very challenging response when you have a rare but deadly mosquito-borne disease in your community that most people haven't heard of before. We have a person in my community, a teenager in my community, who is permanently disabled because of mosquito bite. We have multiple people in both my jurisdictions of Calhoun and Kalamazoo County who died of a mosquito bite. And at a time when this information was emerging and was new to many people. And what does it mean for a community to hear from public health professionals, medical professionals, to advise an airplane flying over your community to eradicate mosquitoes, which is very common in places like Florida, in southern parts of the United States, where it's a routine public health practice and accepted by their communities, familiar with it. But for Michiganders who had never heard of that before, it was scary for a lot of people. And that was a very challenging risk communication. And this is all prior to COVID as well. And the last I would note would be our hepatitis A outbreak. The largest hepatitis A outbreak in Michigan's history happened a couple of years ago, was related to a drug overdose epidemic in Michigan and required a coordinated response too. So this is just another examples of how emerging diseases and diseases have been around for a while affect the health of individuals and communities and that local public health response to.
Yeah, thanks, Dr. Nettleton. So let's talk a little bit about your role as a medical director. Both Nick and Linda are administrative health officers, and you are the medical director. And there are a few situations in Michigan where we have a combined role of health officer and medical director. But what would you say? You've talked a little bit about risk communication. What other responsibilities fall within your purview? And how do you function as a member of the leadership team at your counties?
Yeah, thanks for the question, Norm. I think that's important to distinguish as well. There are two medical health officers that I'm aware of in the state of Michigan. So they serve as both a physician and as a health officer, Genesee County and also St. Clair County. When the health officer is not a medical doctor or doctor of osteopathy, public health code requires a medical director who provides advice and counsel to the administrative health officer. The requirements for that include training in both medicine and in public health. For example, I'm board certified in preventive medicine and public health in addition to family medicine. Other options include having a master's degree in public health and experience in the public health practice. So generally, I see my role as a medical director. One, I'm responsible for the medical policies and procedures of the health department. I also provide guideposts to improve the health of our population in our community. And third, I often act as a liaison between what happens in public health and what happens in the medical community. So specifically, I'm responsible for the standing orders for the health department. That includes vaccinations, antibiotics, treatments or outbreak response. And so that also includes oversight of clinics, including our sexually transmitted infection clinics, our tuberculosis clinics, our communicable disease teams. I also do direct patient care in the health department for tuberculosis patients. I advise and I train our nurse practitioner and family planning, for example, birth control practices for those who have Title X in their health department or may have an FQHC in their health department. I also am part of the leadership team, as you pointed out, Norm, and that is a key part of a medical director's role. I often do public education, public communication, which includes media response as well. Folks want to hear the advice and impression of their local public health physician. Besides that community education, there's that topic that I brought up and you touched on, Norm, which was risk communication. What is the risk in our community? And we see how important that skill is in the pandemic. and in every public health response. I already mentioned our EEE outbreak. How to describe the risk for the community where it's rare, but the outcome is severe. That's challenging. How to communicate the risk when public health professionals are concerned, but the general public is not concerned. Or when the public is very concerned and the public health professionals are not. That is a skill known as risk communication that the medical director often works hand in hand with the health officer to do and address. And so I also work closely with our epidemiologist as well for health assessments. You know, when I started in my role 5 years ago in Calhoun and Kalamazoo, listening in our community, meeting with community leaders, I quickly identified our opioid overdose epidemic as being a severe public health challenge, and really sought to bring folks together and form our Calhoun and also our Kalamazoo County opioid coalitions to bring a public health lens to address the topic from a public health perspective. So that was another example where the medical officer works with the health officer as the chief health strategist for the community as well. And I guess that final point, Norm, is that medical directors work closely with their health officers in this type of response, but also in terms of public health planning, preparedness, engagement. I think about our COVID-19 pandemic and working with our superintendents in our local school districts, working with our local hospitals. I'm often the consulting physicians for doctors in our community who call and request public health advice. And I take that role very seriously. So those are just some examples of the role of the medical director or medical officer in concert with the health officer.
Thanks very much. And so we learned in the first half of this two-part series that a health department in Michigan cannot legally function without an administrative health officer and a medical director. And sometimes, again, those are combined positions, but I think that there has been some confusion about when the press reports that a health officer has taken this particular approach or has implemented a public health order, and that person is not a physician. And this kind of helps to explain how those two roles interact and why they are both very critical in order to keep the public health system functioning.
Yeah, Norm, if I could mention one more thing. I mean, it is very much a team between the health officer and the medical director. We work very closely within our communities, and there are times where, you know, it's extremely beneficial to have our local medical director with that medical background be able to work with our local hospitals, physicians, or speak to different groups. One thing that Dr. Nettleton and Linda had both mentioned that I think we really should probably emphasize here is there are a lot of things that happen locally that our citizens are very concerned about. And they may not be a statewide or national issue most of the time, but it's a local issue. It's very important to our local populations, and they look to the local health department for that guidance. And we've provided it. We've been a trusted source of information within our communities for a very long time. COVID, I think just the volume of news coverage, national, state, local, all across the board is really just an unusual and unprecedented time where folks are having to sift through a lot of information and sources. In normal times, local health departments are often the trusted source within their communities that both local agencies and entities and the general public are coming to for that guidance. And local health officers and local medical directors are really respected in our communities for that guidance.
Right, right, absolutely.
Norm, I'll just take a second right now to remind attendees that if you do have questions for any of our panelists, feel free to drop them in the Q&A and we'll take them I'll be monitoring and we'll take them periodically throughout the session. Thank you.
Okay, thank you, Kathy. So Nick, I think that in some cases, there's a perception that because the public health code gives the health officer certain powers and duties, the health officers are really have unlimited authority and limited accountability for what they do. in their communities. So how do you respond to that?
Yeah, thank you for the question, Norm. First, I do want to point out that Michigan's public health code has been in place since 1978. So I think the point that we're having this conversation right now speaks to how rarely those powers within the public health code are used. It's been in place a very, very long time, and we're now just having conversations about the breadth of the authority within the public health code. And those authorities for both a local health officer and a state health officer are very, very broad. There is broad authority within the public health code to be able to respond to emerging threats or emerging diseases within a local community in order to keep our residents safe. Now, that said, with that authority also comes responsibility. We are responsible. We are the individuals responsible within our communities to keep our residents safe. So not only do we have that authority, we also have that responsibility. That's the work that we do. We need to make sure that we are implementing measures and programs and doing everything we can within our authority to keep our residents safe. On the accountability side, I would say that there is a lot of accountability for local health officers to both their local governing entity. You have your county commission, your board of health, or district board of health for a district health department. Those are our bosses. Those are the folks that we are accountable to, but we are also very accountable to our citizens. We interact regularly with our citizens all the time. We live in the communities that we serve. We hear feedback from those citizens, and our programs are largely a reflection of the communities that we serve and implementation of measures that work within our communities. So the authority is very, very broad. I think that it needs to be, because threats are unknown. It gives us tools that we need to be able to respond to things that aren't defined. They come up at unknown times, and it gives us tools to be able to respond to those. But there is also responsibility, and there is very much accountability to both the local governing entity and citizens.
Thank you. Very good. So there have been a few, well, actually, there have been many attempts to limit the authority of public health officers. And some of those have been local. Some of them have been statewide. There are at least a couple that are statewide. And the ones that are statewide, there is an effort to limit the authority of local health officers to implement emergency orders to a period of 28 days. And then in order to extend that order, it would have to be voted on either by the local governing entity, which, as you mentioned, Nick, could be the county commission or a district board of health, depending on the composition of the jurisdiction, or by the state legislature. So Linda, maybe I can ask you to address this question. What is your perspective on that? And how do you think that if that were successful, how might it impact public health in Michigan?
Well, first, I understand, kind of where that has come from, given that we are in 2 years, entering year 3 of a pandemic, and before we've just never seen this kind of authority needed to be used. But again, not only does Dr. Nettleton come to his position with a requirement to have a preventive medicine degree or an MPH or both. My medical director is board certified in internal medicine, infectious diseases, preventive medicine, and has an MPH. We are required to have a MPH or a related degree and a certain number of years of experience as administrators in public health. We have to have a background. We are nurses, we are environmental health experts, we are a number of different things. I came into this with a microbiology degree and a research background. And so we are equipped with the tools to basically understand oftentimes some pretty sophisticated science, and to really look at predictive models around things also to kind of help us anticipate, where we're headed and things. And so it does give me great concern. I mean, we know that the public health system in the United States has been around for a long time, since the late 1800s in Michigan, with the public health code since 1978. Nobody's ever questioned that before. And in fact, people have relied on us to use that authority to protect them. They just didn't know that we were going to have to use that authority to protect them for quite this long. But a pandemic, which has a fairly high mortality rate compared to flu and things like that, and a virus that we're literally still trying to figure out, will put you down that path. So, it deeply concerns me that we would get to a position where we abandon that scientific and public health expertise that goes into making those decisions, and just say that those decisions are now going to be made, in some sort of a kind of political way, if you will. So, we've seen boards of commissioners and things like that try to restrict the authority of their public health officials in certain ways, withholding fundings, things like that. We've seen some pretty challenging situations out there. All of us have been challenged in some ways with what's going on. But I will tell you that, we needed that 2 years worth of getting oil out of the Kalamazoo River. And I think every citizen in Kalamazoo and Calhoun County wanted that to happen and wanted that river to be cleaned up. And those orders that kept that river in a place where there was no contact allowed in there, because people boat and duck hunt and do all kinds of things throughout that river, was critical. And that went on for 2 years. That's a different kind of order. It's an imminent danger order rather than an order to control an epidemic. But I do think if we start to go down the path of changing the public health code to restrict public health decision-making, which comes out of a place of expertise and science and extensive training, that we're going down a very dangerous road. I myself, and I'm sure Nick as well, have been accused of being a bureaucrat that sits behind a desk. And that just truly is not where we come from to get into these positions. We aren't just generic managers that rise to a level to be able to run a department. We are trained epidemiologists, scientists, nurses, those sorts of people that have some leadership skills that rise to a level of being able to do both. One, lead, and two, really be able to interpret science, public health, guidance. I mean, look at what's happened with guidance from the CDC in recent months. It's ever changing. It is very confusing to the public. Oftentimes it's a little bit confusing to us, but we're able to dig into that and really, figure out where that guidance needs to be appropriately applied within our communities, whether it be CDC, World Health Organization, or state level guidance. And, I think I'll build on Nick's accountability piece in a way. And I think we're held accountable in that way as well. I think that we have an international organization that provides guidance, that tells us where we are and what needs to be done with regards to certain public health issues. Then we have a United States level, the CDC level, public health entity that provides us guidance and information for us as public health officials to lead with, and then at the state level as well. So all of that together is really it's a situation where you just need to leave that person who has been trained for many years in all of those things, as well as following the guidance of those multiple different layers of entities in order to make the best possible decisions for the citizens in our county. They aren't always easy decisions to make. They aren't always popular decisions to make, but I will tell you that if we make them, they are always necessary decisions to make.
Yeah, Norm, and if I may add, I totally agree with Linda. I understand frustration with the length and duration and some of the measures that had to be put in place as part of the pandemic, but I do think a decision to limit a public health order to 28 days would be very, very short-sighted. We don't know what is on the horizon, what may arise as far as an emerging threat at any given time. Now, that said, we all know, we all agree in public health that this pandemic response has been unlike anything that we've seen. This will be undoubtedly a learning opportunity. We will look back, we will look at the things that worked, the things that didn't work. There will be countless opportunities for improvement as we move forward. But I think just picking one thing out as part of this response and making a change to the public health code that could be a profound change impacting responses in the future would just be a very, very short-sighted mistake.
And just to build on that slightly again, and that is that part of the public health code, like I said, a epidemic order is for a group of people. Spinning off of that and directly connected to it is warning notices for individuals. That's the same part of the public health code. So these individuals, for example, who are in our community with active tuberculosis, and we're trying to keep them from being in, certain places, or in our community with other diseases that might be threatening, and it's just an individual person, we might have to use those warning notices for certain periods of time in order to make sure that those individuals are not then basically putting others into dangerous situations. So those two really are paired together. The part of the code that then becomes towards an individual and a warning notice comes out of the very epidemic order that is kind of on the table at this point in time to restrict.
Yeah, Norm, if I could just add, my thought too, and just highlight what Linda and Nick have said about highlighting the unpredictable nature of a public health response, an ever-changing situation. Would I have predicted in my last 5 years that a deadly mosquito-borne infection would have threatened my entire community? Could I have predicted that we told the entire community not to drink the water? Did I anticipate an entire pandemic happening? It just demonstrates the unpredictable nature of emerging threats. Another example is on just last week, I was notified in Kalamazoo County that a flock of birds happens to be infected with avian influenza, which has the potential to cause another pandemic. And that was just me, after rounding in the hospital, being notified of that and thinking about local response and preparedness. That type of incidence of emerging threats happens routinely in public health. And sometimes it's predictable, most of the time it is not. And then it comes back to those who are making decisions. We are members of a profession of public health. And that comes back to what Linda mentioned as well. What do we respond to? We respond to evidence, we respond to our prior experience, and we respond to our peers' own expertise and their own experience. That is what we respond to when we make decisions rooted in our profession and a deep sense of duty to protect the health of the public.
So Dr. Nettleton, I am curious to have you talk a little bit about your role as a physician. So you are trained as a family physician, among other things, and your role as a medical director. So can you talk a little bit about kind of the difference you see between those two kind of roles? And you have a master of public health, so going through medical school just wasn't quite enough for you. Did you feel when you came out of, as a family physician, did you feel like you would have been prepared to understand these kind of public health functions, or how did your training in public health sort of augment your training as a physician? And I guess the second part of that is when we think about legal issues or litigation, or if a potential lawsuit came against your public health department, what would be your role as a medical director in responding to that litigation?
Yeah, thanks for the question, Norm. So the practice of medicine and the practice of public health, I think about they are different professions with different perspectives. So medicine, I am trained to diagnose and treat individual patients one at a time. In public health, broadly speaking, the patient is my community. The community is the patient. That takes a different perspective and an entirely different skill set. Skill set in public health includes epidemiology, biostatistics, health management and policy, communication. All of those, in addition to more, are different. It's a different skill set entirely, but they complement each other very well, particularly when we have to make medically based decisions on a population level. And it's also a difference in perspective on an individual versus population health and ethics. The ethics and duty for me in medicine is that one patient in front of me at a time. I'm entirely devoted to the care for that one patient until I no longer have that duty. And that has multiple forms of ethics based on autonomy of the patient, based on doing good on behalf of the patient, based on doing no harm. And another core medical ethic that I highlight for residents and students who I teach is justice, and in terms of working on behalf of fairness for that individual. But in public health, the core ethic is justice, is working on behalf of the entire community to ensure that everybody has the same opportunity to have their best health. And that's working towards health equity. So physicians who work in public health have a unique balance of seeing the individual impacts of public health, whether it's when I take care of patients who have COVID-19 in the hospital and seeing their suffering amongst themselves and their families, and then when I make decisions for my community about COVID-19. Or when people may shrug off hearing about a rare mosquito-borne disease, but I recognize and work with the physicians who are caring for those patients in the hospital who are completely and utterly disabled and have no functionality based after that mosquito bite. I'm able to see that suffering and translate that suffering and work with those in the medical community and those families to translate that to what happens in a population. Oftentimes I highlight the fact for our students that only 10 to 20% of a person's health is determined by medical care. The majority of a person's health is determined what happens outside the exam room, outside of the medical environment, where they live, where they work, where they play, what decisions they make about their health, and then a smaller part about their biology. And that surprises a lot of folks. It surprises a lot who work in healthcare. But the majority of what affects a person's health happens in the community. And that is one of my roles too, is highlighting that fact and translating what happens in the practice of caring for individuals, and then working on behalf of the common good for when the individual health factors really need to be addressed on a population-based level. So translating, well, we have an outbreak of sexually transmitted infections that are sending people to the hospital. That happened in my community. People forget that some sexually transmitted infections send people to the hospital. Translating what it means to how do we reduce infant mortality and racial disparities between Black and white and other racial backgrounds for infant mortality. That's a population-based issue that cannot be addressed only by a physician. Translating for communities what it means that, yes, it's important for physicians to be involved in reversing the tide of the opioid overdose epidemic, but individual clinicians and those who practice medicine can't do it alone. They need a population-based approach that is tailored to the communities that they live in. So oftentimes that's the role that I play, and bringing that different skill set and that different perspective to those interventions is why it is important for people with a background in medicine to also be practicing public health. But that public health training and background and perspective is critical for those who practice medicine and public health.
Thank you. Thank you very much.
Oh, you know what? I didn't address your second question, which is
Yeah,
about lawsuits, I think, and
yeah,
medical
if you-
malpractice.
Right. So there's difference between legal issues as a physician treating individual patients and as a medical director who is responsible to the community, right?
Absolutely, and it depends upon your practice environment and that engagement. So for example, those who bring a lawsuit against a county or a health department, I can serve as a representative of the county health department, providing that medical expertise to the health officer and to those who are making decisions in litigation. That's often would be my role in that case. And that's different from individual concerns about tort or something like that, when the individual one-on-one decision-making and relationship with a patient. They are different. County health departments should serve their medical directors and provide that malpractice insurance. But different set of law on practicing on different circumstances on an individual versus population-based level.
Thank you very much. So Nick, let's come back to you and talk about, I think that another point of confusion is that sometimes these emergency public health orders come from the local health department, and sometimes they come from the state health department. And so can you talk a little bit about why that is and clear that up for us a little bit?
I'll do my best, Norm. So Michigan's public health code was written giving equal authority to both the state health officer and the local public health officer. And that was done based on the fact that we've discussed here quite a bit. These responses can be unpredictable. So we don't know the scope of emerging threats that may happen. COVID being a good example. The entire state was impacted at various times. State orders were required, state mitigation measures in order to keep individuals safe. We've had several examples where that wasn't the case. We've talked about PFAS. We've talked about the oil spill in the Kalamazoo River. There were issues years ago up in the UP. There were some facilities selling designer drugs called bath salts. Folks were winding up in the emergency room very quickly after taking these drugs. So local orders were issued in order to stop these facilities from selling drugs and making individuals sick. So there's equal authority based on the size and scope of the response that's necessary. One criticism that we've heard pretty recently is that when there are local orders, there's variation, and that's absolutely true. All of our communities are different. Communities have different resources. They're impacted differently at different times. So that is actually one of the pros of local authority within a local health department. So you can do things within your jurisdiction that's necessary to keep your citizens safe, where there's a neighboring jurisdiction that may not be as heavily impacted or impacted in the same way, where a local order is not necessary. It's not unusual to public health. I mean, we see it across the nation. There are some things that are a federal response. There are some things that are a state response. And there are many things that are a local response. So I think there are definitely pros and cons to both systems, but I think the benefits of having that local authority, the local ability to respond, and the local accountability to our local governing entities and our citizens is extremely important. I think that system where there is the local input, there is the ability to tailor responses both on local needs and local resources. I think that's an amazing system. I think while there are drawbacks to it, perception issues, I think it's a phenomenal system and has served our citizens well for many years.
I'll just add, Nick, it's Kathy. They came up in session 1 on February 7th. It's also the opportunity, I'm just really highlighting something you said, but the opportunity for the constituents to interact with their public health professionals in a way that could not happen if it was a centralized system, and how important that is, how painful it can be at times, but how important it is for that direct interaction.
Yeah, absolutely. Thank you, Kathy. And it happens all the time. That's what we do. I mean, we work with stakeholders. We work with our local governing entities. We're convening community groups. Our medical directors are working with the medical community. I mean, we're talking to all of the key partners within our local area and being able to listen to the concerns of the public, and to be able to respond in ways that help the public understand, and also in ways that our communities are able to embrace, and with measures to keep our community safe.
I just have one last question that I'd like for each of you to kind of weigh in on, if you're willing. So we've been at this now for 2 full years, and it has, the pandemic response has highlighted some of both the strengths and the challenges of our local health system in Michigan. So as we are moving into this recovery phase right now, as cases are declining, and we're moving toward warmer weather and things like that, we're optimistic that at least for a while, we will see these cases continue to decline. What kind of policy or legal decisions do you all think need to be addressed going forward to ensure that the local public health system in Michigan is prepared as it can be to protect and promote public health in the future? So I'll just throw that out there. Any of you can respond first.
Yeah, thanks, Norm. I guess I'll go first. As I'd mentioned earlier, I think one of the things that, undoubtedly we all recognize we're going to have to do is get together and take a look at the successes of the response, the failures of the response, work with our emergency preparedness folks across our communities and across the state, and see what worked and what didn't, and make changes based on that to our emergency preparedness plans, and put some tools forward that will help us to overcome some of the challenges that we faced throughout this response. I think for me, one of the major challenges in this response was the amount of misinformation that ended up coming out. We really, right from the outset, it only took a very short amount of time, and we were dealing with misinformation. We're trying to combat that with facts and figures and be able to communicate effectively. As Dr. Nettleton mentioned time and again, crisis communication is something that we do and have done. We're a trusted local source, but just the sheer volume of misinformation and the platform that it had and the way that it resonated with some was a major challenge that we had in public health. And that's something that we're going to really have to talk about and find ways to overcome that, as well as the politicization of the response. I think that was something that, I, for one, really hadn't anticipated. A lot of times when we'd done our emergency preparedness planning, we had plans in place. We'd convened local partners. We had discussions about, if this happens, here's what we'll do. And there was buy-in and there was broad consensus. There really wasn't this anticipation that these, what are common, I think, public health activities most of the time, were going to elicit such a political response. And you're going to have such intense pushback from various sides on measures to help keep folks safe. So I think, to respond to your question, I think misinformation is a real issue that we're going to have to talk about and find ways to address moving forward, rebuilding that public trust as a result of some of that misinformation and politicization. But we will look back at the entire response, and we will look at the strengths, the weaknesses, what worked, what didn't, and use those lessons learned to help us have a better plan and a better system in place that's stronger and more robust and more readily prepared for what may come next that we don't know.
I guess I can go next. I really completely agree with Nick on a number of issues there. And I'll say as a, like I said, I kind of had a 2-career thing going on here. I was a biomedical researcher for 20 years. And then I was in public health now for 20 years, have been in public health for 20 years. And, the bottom line is science, as well as public health, which is a field of science, is an iterative process. And so that means that we learn as we go, especially when they are brand new things that emerge that we haven't seen before. And so a lot of the misinformation and a lot of the politicization came out of, well, you told us this before and now you're telling us this. And so really trying to help the public understand also that that's just the nature of what's going to happen in situations where we're learning as we go, which is the way science works. We learn as we go and we change as we go. And so we did that along the way, as well as the fact that we're going to have to do that in a giant looking back at the whole response afterwards to see, what could have been done better, and things like that. I think that one of the other things that is important to note is that, we have 45 health departments in the state of Michigan. So that's district health departments as well as single county health departments. And we also work with each other. So we are very much mentors to each other, colleagues, problem solvers together, and those sorts of things. And so that, we will come together and look at the entire response, not just individually within our communities. And the major challenges have been really, again, the misinformation and the ability to get past that information with the accurate information without also being accused of changing from the last time we told people information, because as we learn along the way, that happens sometimes. And so that evolution of knowledge through a scientific process is very much part of public health as well as any science. I used to say when I was a researcher that we'd have cancer cured, we'd have HIV cured, we've had lots of things cured if every time we set about a plan of, looking for a solution for HIV or cancer or Alzheimer's, we'd have it all solved if there was not an iterative process of needing to learn more before we finally get to those answers. And there are many, many things that scientifically we haven't gotten to the final answer yet. We've gotten better at treating HIV, better at treating a lot of these different things. But there are many, many things that we've had and have experienced in our lifetime for many, many years now that from a scientific perspective, we're still growing and learning through. And I think that we need to help people understand that when it comes to this magnitude of a public health response to an emerging threat that has been completely unknown to us before, that we're going through some of that same sort of processes to get us to a point where we're always making the best decisions we can with the information we have at the time that we make it. And so I think that's very important. We're making the best decisions we can at the moment in time with the information we have at that time.
Yeah, and Norm, I think one of my bottom lines is that the health challenges of the 21st century are going to occur on the level of populations and communities, whether it's chronic diseases such as obesity or emerging infectious diseases. There will be another pandemic. It will likely be in my lifetime. It'll definitely be within my children's lifetimes. And so this type of response, again, whether it's for a long-term chronic diseases or for an infectious disease like a pandemic, require a population-based approach tailored towards local communities. So public health is a public good that requires public investment. I think that's a very important thing for policymakers to acknowledge and to hear. And I'm concerned that there has been focus on this balance, which we always balance in public health, the balance of individual liberty with the common good, and that there has been focus on that, which is okay. But it's important to acknowledge that public health on a local, state, and federal level for decades has been vastly underfunded, underappreciated, and misunderstood. And so these type of conversations that we are having right now are really important, and we should continue to have these conversations. And I worry about workforce development. I worry about the morale of young people who are seeking out which career to go into. Young person who's going into public health can have a lot of impact going into public health. You know, investing in local, state, federal public health has a very large return on investment. The challenges that we are facing in terms of health outcomes, how well we are doing, how well we are living, how long we live, that's public health. The gains we're going to get are going to be investing in public health, not in healthcare. And I'm saying that as a physician who trains and treats patients. The investment is really needed in public health. We really need to invest and to plan for the future, because those are the challenges of the 21st century. And we are connected on a local and global level. And that's one key thing. I think it's very important for policymakers and decision makers to acknowledge and continue to ask questions about and engage your local public health folks on the ground.
Yeah, I think that's an extremely important point, and I'm really glad that Dr. Nettleton mentioned that. You know, for the last couple of years, we've been so, focused on our response and answering questions to the community about, you did this, why didn't you do that, or trying to handle the misinformation. I think what gets lost is how incredibly underfunded local public health had been for such a long time. We came into this leaner than we ever had been. We were trying to wear as many hats as we could and handle and administer as many programs as we could with scarce resources. And then to pile a pandemic of this scope and nature on top of all that work that we were trying to do without enough resources was just extremely, extremely difficult. So I do think a really critical look at an investment in public health, a system that had been underfunded and now is facing really profound workforce development issues with staff lost, folks that stayed around a little while longer to help through the pandemic and now are set to retire. So we're going to lose all that knowledge base. We really need a strong investment in public health to build that system back up. It's been a really, really difficult couple of years. We've lost a lot of professionals. So now I think is the time. And when you really look at the dollars necessary to make that investment in public health, these aren't huge dollar amounts within the state budget, but those dollars can go a very, very long way in helping rebuild the system and have a really, really huge impact on keeping our residents safe both now and in the future.
And I'll just kind of build onto that a little bit, adding on to the underfunding. We seem to go through cycles of, we're in a pretty good funding place and then we drop. And in my 20 years of public health, it's always been cuts, 20 years of watching cut after cut after cut. And going back to more of a chronic disease model, I once saw a presentation, and if I could draw it, I would, but I can't, of a slide that basically talked about when we take individuals who are basically medically progressing in a chronic disease, and we spend a lot of money to try to keep them healthy, to try to keep them from getting sicker. We don't ever really quite get rid of that chronic disease. It takes a whole lot less money to prevent people from getting those diseases in the first place than it does to basically try to manage them and try to keep people from getting sicker after that chronic disease has emerged and you're spending lots and lots of money on the medical side of things to manage that chronic disease and keep it at a steady state level to where people can function, rather than just spending a little less money and trying to prevent those things in the first place.
Well, I'd like to check in with Kathy and see if we have any additional questions that have come in from the Q&A. You know, I guess before we do that, I just want to say thanks to all of you for not only being a part of this panel and for sharing your expertise, but for everything that you have done over the last 2 years. And you're representative of a much larger group of people who have been working, you know, very, very long hours under extremely difficult circumstances and have just shown incredible resilience, dedication, and commitment to the cause. And so, so thank you all for sharing your expertise with us. Kathy, are there any remaining questions that we need to address, or do you have any closing comments or things that we need to know?
Norm, there are not any questions in the Q&A. I will just echo your thanks, not only to this group of professionals, but to all of our public health professionals in our state who have kept our communities healthy through this very challenging time. And before that, you know, with other public health emergencies that perhaps didn't get as much news as the pandemic has. And I will just say, as a citizen and as someone who understands and appreciates the science, it has been really sad to me to see the attacks that have happened individually. This is not at all anything any of you asked me to say, but we have lost some really, really expert and dedicated professionals, public health professionals, due to personal attacks. And that is just so distressing. And I agree with everything you've said of the concern for the pipeline of the public health professionals coming in the future under the circumstances of some of the ugliness we've seen in our state, and really not just our state, but other states. But we have had resignations due to the treatment of our professionals who have done nothing but dedicate. I'm sure you all could tell me the amount of personal hours you have dedicated to this that have happened. I was my pleasure to volunteer at one of the mass vax clinics in Ingham County, and Linda, it was rare to not see Linda there, no matter what hours I was working as part of that effort. So I just really want to thank you for everything you've done, everything you've put up with, for staying the course and continuing to keep our communities safe and healthy. Arnold, I don't see any questions. I don't know if you have anything. The last thing I would just like to remind
I've got a lot of things to say, Kathy.
Okay.
I'll try.
Okay.
And,
let me do a couple reminders and then you can close it up. A reminder to complete the evaluation so that we have ideas for future sessions. It's always helpful to us for that. And to remind you that if you did miss the first session of this series on February 7th on the legal aspects, I think it would be helpful to view that in both recordings. This recording will be available soon, and that one is already available. So thank you again to this panel, Norm, for pulling it together, for all of your time, and again to the Michigan Health Endowment Fund for supporting it. And that's all for me, Arnold, to you.
Well, I too want to thank everyone for their time this morning. The conversation has been excellent. It's been frank, it's been honest, and I certainly appreciate that. As one that works in the broader public policy field, I want to thank you all for, as Kathy noted, your courage over the last 2 years and your work generally as public servants. You are all public servants, and I greatly appreciate everything you've done. I just want to remind our audience that, and you all brought up the point about the cuts that public health has faced, but over the last 20 years, let's be honest, there has been a concerted effort to cut the size of government, which means cuts in public services across the board, K-12 education, universities, public health, healthcare, other types of social services. We can all go down the list. And quite honestly, the disturbing thing is that it has worked. And we need a recommitment to those services that many of our citizens need on a daily basis. And certainly, I think, once again, we've had a health disaster. We've had plenty of natural disasters over the last 20 years point out the need for better government services. And now we've had a health disaster point that out too, and the important work that you all do. So again, thank you all very much. IPSR will continue this conversation, not just in healthcare, but in other areas of public policy. And again, we greatly appreciate your time. And Linda, no problem about your dress today. I found it perfect. So thank you.
Thanks for repping the green and white.
Exactly. So thank you all very much.
Thank you, everybody.